Welcome back to part 2 of our 15-part evaluation and management training series. Whether you're a seasoned medical coder, a meticulous auditor, a biller, or a CDI specialist, you know that nailing the correct EM level is absolutely crucial. It's what ensures fair reimbursement for a provider's time and complex work, keeps you audit ready, and guarantees total compliance. Today, we're going to funnel down from the vast, sometimes super intimidating EM landscape right down to the foundational building blocks of coding. We're setting the stage so you can tackle any chart that comes your way with absolute confidence. Let's get into it. Here is our highly structured roadmap for today's explainer. We'll be hitting Section 1, the EM categories landscape. Section 2, inpatient versus outpatient settings. Section 3, initial versus subsequent visits. Section 4, your EM cheat sheet. Section 5, the outpatient foundation. And finally, Section 6, key takeaways and a quick teaser. Section 1, EM categories landscape. Okay, let's dive right into this massive landscape of E&M categories. Honestly, it can feel incredibly overwhelming to anyone navigating the CPT manual for the first time. But here's a trick to making it totally manageable. Instead of trying to memorize a chaotic list of 25 different categories, we just mentally chunk them. Think of it like 3 distinct buckets. First up, we have our core services. These are really your bread and butter. This includes your office or outpatient services, hospital inpatient and observation care, and emergency department services. Then, in the second bucket, we have care management. Think chronic care, principal care, and transitional care management. And finally, we have specialized services, covering the whole shebang, from preventive medicine to critical care and neonatal intensive care. By organizing the landscape exactly like this, we transform a messy list of codes into a highly organized, logical map. Section 2, inpatient versus outpatient settings. Let's move a bit further down the funnel to our first major dividing line in E&M coding. Because, before we can even look at a code, we absolutely have to establish the physical setting where the care actually takes place. Outpatient care refers to medical services where a patient gets care without ever being formally admitted to a hospital. They come into a clinic, a doctor's office, or even an emergency room. They get their consultation or minor treatment, and they return home the exact same day. On the flip side, inpatient care requires formal admission to a hospital or healthcare facility. It almost always means an overnight stay. This is reserved for much more serious, complex medical conditions that need acute, close-up monitoring by healthcare professionals. Grasping this simple distinction instantly halves the number of code categories you even need to look at. Section 3, initial versus subsequent visits. Now that we know where the care happens, we've got to narrow our focus to when it happens in the patient's overall treatment timeline. This timeline completely dictates the complexity of the visit. An initial visit is pretty much exactly what it sounds like. It's the very first encounter between a patient and a provider for a particular condition. This means you need a comprehensive assessment, you're gathering a full medical history, and you're building a brand new treatment plan from scratch. You are establishing the baseline. A subsequent visit or follow-up happens after that baseline is already set. So the focus here naturally shifts to ongoing monitoring. Is the patient responding to the treatment? Do we need to tweak the medication? Because the baseline is already there, the complexity of a subsequent visit looks very, very different from an initial one. Section 4, your EM cheat sheet. So let's put all this foundational knowledge into a quick reference cheat sheet for your daily workflow. Having a solid mental filing cabinet instantly aligns the setting of care with its corresponding CPT code block. For outpatient office visits, you are living right in that 99-2002 to 99-2015 range. Hospital inpatient and observation jumps over to 99-221 through 99-239. Consultations sit snugly between 99-242 and 99-255. Emergency department services are 99-281 to 99-288. And nursing facilities are 99-304 to 99-316. Now, why does mapping this out matter so much? Because as our source materials explicitly state, levels of E&M services are not interchangeable among different categories. A Level 3 office visit absolutely does not have the same definition as a Level 3 hospital inpatient visit. Keeping these ranges straight guarantees you always start in the right section. Across all of these different code ranges, what truly drives your medical decision-making, or MDM, is the problem addressed. But what does that actually look like in everyday clinical documentation? Well, a problem is addressed when it's actively evaluated or treated at the visit by the reporting provider. Here is the absolute crucial point. This even includes situations where the provider formally considered further testing or treatment, but the patient ultimately chose not to proceed due to a risk-benefit analysis. It still counts. However, simply noting that another professional is managing a problem without your own active assessment does not count as addressing it. That is a massive distinction for auditors and CDI specialists to watch out for.
Section 5. The Outpatient Foundation.
We've reached the very bottom of our funnel, targeting the single most important code set in your entire E&M toolkit. Mastering the office and other outpatient codes, specifically 99202 through 99215, is your core foundation. The way we score medical decision-making, the way we calculate time, and how we determine the overall complexity of a problem, all of that stems directly from the guidelines established for these outpatient visits. If you can master the specific nuances of these outpatient codes, you literally possess the foundational blueprint required to confidently navigate every single other category in that huge 25-category landscape we looked at earlier. It's a real game changer.
Section 6. Key Takeaways and Teaser. Let's wrap up today's explainer by solidifying what we've learned and peeking ahead to the next step in our 15-part journey.
To summarize our blueprint today, we took that vast landscape of 25 E&M categories and organized it into a logical, easy-to-use system. We've established that the physical setting, whether a patient is admitted overnight or goes home the same day, always dictates your starting code block. We've learned that the timeline of care, initial versus subsequent, totally dictates the complexity of the visit. And above all, we've firmly established that mastering the outpatient office visit rules is your absolute key to E&M auditing and coding success. But here is a provocative question to leave you with, and honestly, it's one that trips up billing departments every single day. If a patient hasn't been seen in exactly 3 years, how exactly do we classify them? Are they a new patient or an established one? How does subspecialties impact this classification? And how does the infamous 3-year rule actually work in practice? Join us for Part 3 to find out. Decode Healthcare with Harshal.